So hello everybody, and thank you for joining us for another one of our specialists seminars. Today we have the very lovely Dr. Divy Dua, who is a medical oncologist. He has special areas of interest in relation to thoracic malignancies, but also genitourinary malignancies, and he's actively involved in research, in leadership within his field, and in hospital management of the oncology discipline. He's been working with us for a couple of years. He writes an excellent report and is absolutely lovely to deal with. Today's topic is deciphering PSA, which is to do with the prostate readings, to do with that cancer, one of the major cancers for men.
And then my wife developed
Mr. Jarvis, so I'm just going to mute you, please. There we go. Now, may I ask if you could all keep yourselves muted whilst Dr. Dua is speaking, unless you have a question of something that you absolutely can't understand and needs some clarification, but there will be time for questions at the end of the seminar where you can unmute yourself and ask your questions. So once again, thank you so much for joining us, and over to you, Dr. Dua.
Thanks, Michelle. As I said, I'm Divya. I'm the medical oncologist, and I have been doing this for almost 10 years now. So I thought this topic was quite important for the medical legal aspect, because we've been asked quite commonly in terms of the PSA and whether if it was done a bit earlier, or when it was done, what is the implications, even if it is not picked up, what is going to be the challenges. So although it's a very simple test, it is not something which is very new, but it is something which makes a very important difference in terms of how we manage these patients. I just wanted to bring forward what this test involves, how is it done, what are the implications, and have got some case studies to highlight what the PSA actually just means. It is quite important that PSA has got a different value or meaning in terms of where we actually, whom we actually test, what age group we are testing, and what symptoms these patients have, because that just becomes quite important. So I don't intend to have a lot of slides and a lot of information. I think my view is to just give you some overview of the PSA, and then we can have a discussion at the end in terms of the questions, in terms of how you find how we can actually use this test, and any questions around it. So we'll make a start at just trying to figure out what the PSA is, how is it done, and and how we use in a clinical practice. So PSA is what we call is a prostate-specific antigen. It is the name commonly used for a protein which is normally secreted by any healthy prostate into the semen. It is a kallikrein protease whose biological role is to actually break down the high molecular weight proteins that come out of the seminal vesicles. So seminal vesicles are organs for the testes. The whole reason to bring this fluid into the body is to basically, in the seminal gel, is fluid formed to help the sperm flow free. Because when the sperms are there, they attach some heavy proteins, and we need to break these proteins so that they can actually, in healthy males, they can actually fertilize. PSA is something which occurs naturally, but sometimes these molecules can escape from the prostate into the lymphatics, into the bloodstream, and we can measure. The PSA concentration in a normal person, we're talking here, this is just a normal person, we're not talking about cancer here. So PSA in a normal person in a blood is about 1 million times lower than what if we were to take the same sample from a semen from the same person. So small amount of PSA will always be measured, because our test in most of the labs cannot go anything lower than 0.01. That's why it is still detected, but the quantity detected is actually quite small. Prostate-specific antigen is tissue-specific. It is not cancer-specific. I want to reiterate the fact high PSA does not equate to cancer. There are situations we all need to be careful, but any amount of PSA automatically does not mean cancer. How the test is done? So this test is done by taking some blood, like any normal blood test. There are some mechanical factors. Anything which stimulates the prostate, which is through anything which you have had an exercise, heavy exercise, ejaculations, or somebody has had a rectal examination, anything 1 to 2 days before can cause a rise in PSA. PSA, once it is done, it should be done within the same day. Otherwise, the test is not reliable. Different labs have got different values. But for our last 5 years, they're trying to standardize the testing. As the prostate gland enlarges, which could be a benign enlargement, the PSA will increase, because as the prostate grows bigger, it secretes more enzyme. More enzyme gets through the lymphatics into the bloodstream, and the value goes up. Same thing happens with the cancer. Cancer causes the prostate to grow, more protein into the bloodstream. Normal values can range from 2 micrograms in a young man to up to 9 micrograms in somebody who's probably 75 years and older. There is an age-related cutoff, and then usually if the PSA sits in that value, we can be quite confident, 95% specific, that this is age-related rise in PSA, and there are different nomograms available to measure it. So as a clinician, even as an oncologist or a general physician, if somebody asks you that they just want a PSA test in the absence of symptoms, then you need to counsel these people. It is not at any cancer specific test, we need to go through the pros and cons for the test. So obviously the PSA, we need to make the patient aware that if the PSA value is above the normal, then I think it is likely, or there is high chance, this could be cancer, or this could be a benign enlargement. Any rise in PSA, which is not specific to the age group, will lead to more testing. It will all lead to more testing, which can cause a little bit of anxiousness in terms of the outcomes for the test. What are the indications? Why do we do it? The whole idea of doing a PSA is to actually find out, and if person has a cancer, and they should be counseled in terms of, if you had a test, what does high PSA means? High PSA means that it needs more testing. It does not need cancer. There has been a lot of testing. There has been a lot of concern that we should be universal screening for PSA. Given the biology of the prostate cancer, which is quite long, it has never been shown that universal screening with the PSA will decrease the cancer incidence of prostate cancer. It has to be always in combination with symptoms. It always have to be combination with the clinical examination, which makes the predictive value of these tests higher. So second reason why we use a PSA is somebody that we want to make sure that their treatment is working. Somebody who's had his prostate removed. Once you remove the prostate, the PSA should go back to almost close to zero. Then you monitor this PSA over a course of time. If the PSA were to rise back again, then you worried about the cancer recurrence. If somebody has had his prostate out and the PSA has not dropped back to zero, you need to be considered that there is already evidence of cancer spread. Similarly, somebody who's had radiotherapy to the prostate and the PSA does not drop, or it drops and goes up, it means that there is spread of cancer. So PSA can help us to find out if somebody has a cancer, or once we know it is a cancer, PSA is used to monitor the risk of cancer as well. Some early stage cancers who have rise in PSA and they've got their lower grade cancer, we can use PSA to watch it as well. Not all prostate cancer needs surgery. Not all prostate cancer needs radiotherapy. Not all prostate cancer needs any treatment. There is a subset, 1 in 3 prostate cancer does not need treatment. There are some other benign condition which causes rise in PSA. Prostatitis, example, is an inflammation of the prostate which can cause rise in PSA, which cause symptoms which are quite similar to the cancer, which will have a deep-seated pain, tender, boggy prostate when you actually do an examination. The PSA level has got an acute rise, and after treatment with antibiotics should come back to normal. This is what a prostatitis or inflammation should actually look like. We should be careful that PSA is not a diagnostic test. It assists us to make a diagnosis, but it is not. We should not solely rely on PSA. We also need to be careful that if the PSA is rise, then I think this should be followed by examination, symptoms, biopsy, etc. There are some medication which has an impact on the PSA levels, such as anti-androgen, which are basically blocking the testosterone. These drugs can cause a rise, decrease PSA. Alpha-adrenergic blockers such as prazosin, which are most commonly older generation blood pressure tablet. Cyclophosphamide, which is older generation or first generation chemotherapy drugs, such as methotrexate used for rheumatoid arthritis. Herbal treatments like mushroom treatment can affect PSA. And obviously, when we are obviously referring to the surgeon, we need to make sure that we advise them what medication they're on. What does the results mean? The results means rapid rise PSA could be benign, could be cancer, could be inflammation, could be infarction, meaning not enough blood supply. Somebody's has a very aggressive rectal examination, bicycle riding, post-ejaculation. So as you know, PSA is non-specific. There are lots of reasons, benign and non-benign or cancerous, which can cause rises. Benign enlargement prostate remains the most common cause of rise in PSA. For these people, we would need to have surgery where this prostate would need to be what we call as a transurethral dissection. They can have lasers. If you have a very sudden rise in PSA from a baseline and patient has symptoms of fever, infections, then you are potentially dealing with an infection. This has to be confirmed with an ultrasound as well. Early stem urine can yield cultures, and that's probably why that's one way to confirm the diagnosis of prostatitis. We always need to combine it with the examination. One of the things that most commonly seen when as an oncologist, you ask for a medical legal report is a doctor not acting on a PSA results. Be somebody with a high PSA with no examination. Some patients with one PSA level with no follow-up PSA. So these are the most common things that should happen. If somebody presents with a routine PSA in an age slightly above normal, should be repeated within 4 weeks. Somebody who, in a very young person with a acutely abnormal PSA, should undergo biopsy to confirm the diagnosis. So it depends upon whom you're treating, when you're treating, how you're treating for these patients. Now that you've actually got a PSA, now you've got what do we do in terms of the management? So men requesting testing for prostate cancer with persistent PSA level in the normal range, they should be followed on. This is a gray zone where I think we just need to risk stratify this patient. People who've got a much more stronger family history of prostate cancer should be given priority. Men with PSA less than 1 on annual testing are a very risk of low prostate cancer and should be reassured and should not have ongoing testing only when the symptoms. Or the other issue is they could be stretched out to once every 2 years until they reach age of 65 years. If the PSA is unexpectedly elevated, there are no clinical features, more further testing should be done. Obviously, the whole idea of doing a PSA and its association is to detect the cancers early. So PSA are an early detection test. If abnormal, patient needs to be counseled about the nature of the findings. If obviously you find the PSA, then you need to do a specialist referral. They need to do a biopsy. Obviously, the risk from the biopsies are pain, bleeding, blood in the stools, etc. And obviously, once we do the biopsy, then I think we need to make sure that we give them adequate pain relief. Some patients, especially the older men, they come back with one abnormal prostate, they have an abnormal ultrasound. But when we do actually, in view of sometimes it is, they have other medical problem, we might just decide to do a waitful watching. We just need to watch them and we need to tell them that we're gonna watch the prostate PSA levels. If that PSA level continues to rise, we would need to act on it. Obviously, we need to think about the risk and the benefit of the treatment. Somebody who's 80 and over, a diagnosis of low-grade prostate cancer is very likely will never cause their trouble in the lifeline. Somebody in the prostate cancer in the diagnosis of 60 would need to be taken a lot more seriously. Obviously, PSA are used by surgeons, they're used by oncologists, used by radiation oncologists to monitor in terms of their role, in terms of the treatment. Regular treatment monitoring 6 months is done by post-radiotherapy, post-hormone therapy. There are small transient treatments. Small rise in PSA could mean that the cancer is growing, cancer is progressing. So we may need to change the treatment. Given the change in the treatment in the last 12 months, that we've gone ahead and there are much more newer generation treatment available in the earlier course of the treatment. There is a push in the oncology world to have the diagnosis of prostate cancer much sooner. Now I want to highlight a few things. These case studies are pretty much to figure out just what we see in the day-to-day life. So this gentleman is called as a SA, 51 years, inquired about, he comes to the GPs asking about testing for prostate cancer. He does have his uncle who had prostate cancer in the mid-60s. Grandfather had a TERP, which is basically for benign prostate. His GP explains him the pros and cons of first degree, and he does he does ideally what it should be done. He does a PSA, which is 0.8, and he checks for his prostate, which is basically normal. Then I think because of his family history and his age, he was put on an annual PSA testing. The road for diet and exercise was, over the next few years, his PSA was 0.9, 1.1, 1.4, and his examination remained normal. Suddenly, then he actually comes back being unwell for 3 days. He's got quite a severe pain on passing urine. His blood pressure is normal. Other examination was normal. His PSA and examination shows a very tender prostate. The urine examination was done, and obviously it was same for culture. His antibiotics was started. His PSA came back as 8.5 from a baseline of 1.4. Cultures was positive, and clearly we are dealing with the case of infection with the person has got a background PSA testing. Later down the track, 6 weeks, 6 months later, the PSA was checked. The reason that we did not follow it earlier is because we know we can already see that immediately after the infection there was a rise, and ultimately it will take a few months for the PSA to return to baseline. What does this case highlights? The case highlights that prostatitis is a common condition. It can be confused with an infection. We need to be careful. Careful testing can cause PSA rise, which could be confused with a cancer pain. There are symptoms, which is pain. There are some testing, such as the examination, urine examination, which needs to be added on to what it does. We've got a second patient who's PA, 63 years of age, basically single divorced, serial monitoring over the last 2 years has shown his normal prostate on examination, but the PSA continues to go up, 4.1, 4.9, 5.8. And then subsequently on the examination has shown a small nodule. He has been given, then I think he goes through the counseling process. He accepts to see the surgeon arranges a biopsy, and he was found to have two cancer foci, which was Gleason 7 and Gleason 6. This is the classification used to grade the prostate cancer. There, when you do the biopsy, you grade them between 1 to 4. You grade them between 1 and 4. You pick up the 2 highest grade in the biopsy. Normal prostate biopsy is done over the 12 different areas. You take the highest, you take the two highest biopsies, and that value is added either 3+4, 3+3, and then that's what the Gleason score comes out to be. Gleason score up till 6 is considered low risk, 7 and 8 is medium, 9 and 10 are high grade prostate cancers. The urologist, and then the options were discussed for these cancers in the local invasive cancer is radiotherapy. He could have his prostate out, or we could just watch it. When we do the wait, in this situation, the watchful waiting is annual biopsies to check for the grade, check for the progression, check for the involvement of the surrounding structures. Subsequently, he went on to have this prostate removed. In terms of the complications of the prostate, we need to monitor his bladder control, which is a major issue, and it takes months for them to retain the bladder control. He needs to be referred for a sexual health specialist, sexual health function. 6 months later, his PSA came back to normal, and he remains on annual testing from there on. So that's a good outcome in terms of the PSA. The last case that I want to highlight is a gentleman, 68 years of age, who came in with symptoms. Examination shows a large prostate with a smooth margin. PSA was 6.8. He accepted surgeons. Pros and cons were discussed. Urology assessment and the biopsy confirmed it was a benign prostatic hypertrophy. At 12 months, his PSA was 7.1, then to 7.0, and the examination remained normal, just similar to what the enlarged prostate. His symptoms continued to get worse. Eventually, he decided to have this done even for the benign one. Was as a complication, but as an expected side effect, he went through bleeding for a few months, and to get the bladder control took a while. An examination of this prostate when he had this testing showed this benign enlargement with no cancer. Obviously, it takes time. It is not the whole reason to discuss the pros and cons, because urinary incontinence in a well-functioning male is quite concerning. It does affect their confidence, and hence it is not an easy thing. Sexual function, bladder control are the two big things, and hence watchful waiting is something that we do and needs to be counseled against any surgery. So that's something which, in brief, about the PSA. I've not gone into the prostate cancer, but I've just tried to stick to the PSA. What's its implication? I'm very happy to have any questions if somebody.
Thank you so much, Dr. Dua. That was really, really very interesting indeed. A friend of mine is actually an anaesthetist and does a couple of urological lists doing those procedures that you spoke about. And anecdotally, they commented, and I wanted to ask you about this, the very real risk of urinary incontinence forever or for a period of time, as well as the risk of the loss of sexual function. Are these reasons why a man might choose to delay surgery or to fail to report symptoms, meaning that by the time he finally does, it could be too late?
I think this is actually very commonly seen in people, especially anybody over the age of 55. They are very aware of the fact in terms of the urinary streams, but they're quite concerned in terms of the side effects. In the risk to urinary incontinence, sexual function is actually quite common. Lots of the patients decide not to report the symptoms or undergo surgery. So in terms, it is not reversible in all cases. So we've gone from a point where in 1980s and 90s, where we just do what we call the radical prostatectomy, where we just actually go in and remove everything. And there is no aim to preserve any kind of nerve or bladder control or anything of that kind. And hence these people ended up with lots of incontinence issues. Subsequently, there has been effort to what we call is the radical prostatectomy with nerves. So they're trying to basically dissect nerves so that we can control the bladder. Whereas nowadays, there's something called a robotic, where they basically trying to avoid the bladder and trying to dissect the prostate from the bladder with the view of minimal damage. So I think the techniques are getting better. Regardless of what we do, surgery, radiotherapy, there is a very general risk, and it has got a significant impact on quality of life. We do underreport in literature the quality of life and the sexual health, which is underreported. But in terms of the day-to-day practice, sexual health and the impact on the marriage, impact on relationship with partner is very major issue, and it's something which makes a very big impact on how we manage the prostate cancer.
Absolutely. One of the other questions that I have from someone is prostatitis a precancerous condition?
No, there is never been shown that prostatitis will lead to cancer. Prostatitis can leave you prostatitis is not it's not a rare thing, but it's not something that you see very often. But prostatitis might give you a bit of scarring on the prostate, but it will never lead to cancer.
Right. I have two more questions, but please, anyone else there, if you wanted to unmute yourself and jump in. The next question I have is, are people who do long distance cycling, bike riding with those little seats, are they at any greater risk of problems with their prostate because of riding bicycles?
Answer is yes. The whole reason why the bicycle riding comes is the repetitive trauma to the prostate. Because you are actually, if you're riding a bike for a very long time, there is an on, and these people are the one who's quite used to driving for long, and it is just the regular with the seat and the regular trauma that you're actually getting to the pelvis. It will still take years and years for the cancer to develop, but that is a genuine risk.
Right, I thought so. Brian, you have a question?
Yes, I do. Doctor, thank you so much for presenting this evening. You mentioned the term watchful waiting quite a few times. Do any of your patients choose active surveillance rather than watchful waiting?
I think watchful waiting, I mean, you could use the word watchful waiting means just watching the PSA and not doing anything. Active surveillance would mean that you're coming in and you're getting repeat biopsy. That is the difference between watchful waiting and active surveillance.
So I understand the idea is to minimize the amount of intervention.
Yes.
where the risk is low.
Yes. And the reason people would chase active surveillance is because they do not want the prostate out. And they want to have the maximum time spent without having to undergo the prostate, but they acknowledge the fact that yes, they are willing to act if the condition changes, if the prostate cancer, the grade changes, and then they don't have a choice.
Right. We mentioned before with the removal of the prostate, but you talked initially that the levels of PSA are the highest in the semen and the seminal vesicles.
Okay.
So if the prostate's removed, does the body still produce PSA in the seminal vesicles?
Yes, you will still have quantities, but the conventional test that we have cannot measure the nanograms. Any lab cannot measure the nanograms quantities in PSA, but yes, the answer would be produced. There will be small amounts still produced.
Right. Wow, it's so interesting. And so how far it has come from such a radical and very serious operation to now the very real recollection that people can live with this cancer actually for quite a long time and be more conservatively managed, maintaining normal function across a number of areas. That's really an amazing advance. So
the prostate cancer is amazing to the fact that about 15 years ago, we would tell these people that you are actually, and then most people will just have treatment and we just watch. to the point now, even about 5 years ago, we said, look, anybody who's get the diagnosis of prostate cancer, we bring the chemotherapy upfront. It makes you live longer. The graphs was just an enormous difference. And for all of us, we now see people immediately after the diagnosis of prostate cancer, most people will undergo chemotherapy at upfront diagnosis, which was not heard of. Now, 5 years later down the track, now the treatment is, why wait for these men to have problems later? We want to use our best treatment upfront, because we know with the prostate cancer, we can change the biology, where we use the best treatment upfront, and we can actually make them live longer.
Fantastic, fantastic. So does anyone else have a question? Brian?
Just one more. Doctor, you mentioned that there may be a small bounce in PSA following treatment. How high of a bounce would that be? How long would that bounce last? And what diagnostic would you use next if that bounce lasted too long?
So there's a few. If you find that somebody has gone a prostatectomy, and suppose they start off with a PSA of 6 or 8, and then the PSA drops back to say 0.34, 0.1, and then suddenly they come back for a 3-monthly visit and the PSA is actually 0.3, you will have another test in 4 weeks' time and the PSA does not fall. You would be very suspicious that in that area of what we call the prostatic bed, the cancer is growing. Same situation happens with radiotherapy. Somebody who's had radiotherapy, they come back with a PSA goes up. Then I think you've got a 50-50 chance of whether this is a post-radiotherapy inflammation versus the recurrence of the cancer. And obviously, if you were to really, if you are concerned about that one, these people will undergo MRI and a PET scan to confirm for the recurrence. And also there's a term which I want to highlight, which comes up most commonly in this medical legal space, is something called the biochemical recurrence, where you, in post-surgery, post-radiotherapy, you find that the PSA has actually gone up. You do a PSA has gone up, but on scans, on conventional imaging, which is your CT scan and a bone scan, you cannot find any evidence of metastasis or any spread. That's called as biochemical recurrence. So what's happening is there is a potential focus of cancer, which is in the bloodstream. We are measuring it in the bloodstream, but it has not gone enough to be shown onto any of the scans. The reason is because our scanning has got limitations. All scans cannot pick up everything. They have to have a minimum size before they can be seen on the scans. A negative scan does not mean that they do not have the cancer. They just mean the cancer is not big enough to be picked up by the scan.
Right.
That's why the term is called as biochemical recurrence.
Lovely. Jane, you have a question.
Yeah, I've got a nursing background, so I tend to be the medical expert, whether that's not true or not, in my family. So my brother has constant urination issues that he's had the PSA and everything checked, and everything has always been within normal limits. What could be the other cause of this funny situation that he has with urination, where he'll urinate and then feel like he's finished, but then he'll go back, he'll go out, and then within 5 minutes feels like he needs to urinate again. A recent ultrasound produced the same sort of result. He had emptied his bladder. The sonographer said to him, "Can you go and empty your bladder again?" And he went back to the toilet and he could empty it again, even though he felt he had finished urinating the first time.
So, I mean, there's two things there's two things which needs to be careful about. I think the most likely cause that he's got is he's got what we call is a bladder irritation, where if you imagine that you're actually standing up and bladder is like the urine sits at the bottom, then you've got a bladder neck, and as soon as there is any little urine in his bladder, the base of the bladder just contracts and wants to get the urine out. That's what in the women, what we call is the urge incontinence, where you basically have an urge, the bladder, as soon as there is a little bit of urine, it just contracts the bladder. It just feels that he has to go to the toilet. It is basically something to do with, for some reason, the bladder is actually irritable. Usually the ways to treat are, we normally would recommend people to have the urine alkaline. We make sure that he's on regularly something which we can make the urine less acidic, the change in diet. If everything fails, I think he would need a urodynamic studies, and he potentially would need Botox to the base of the bladder neck. That's usually would be what needs to be done. I'm not saying this is what it is, but out of 10 chance, this is what we are dealing with. There is also some condition called a non-secretory PSA for prostate cancer, where you basically can have a cancer with a normal PSA, which is called as a non-secretory prostate cancer.
Right.
You can have a normal PSA with a cancer.
And how would that be detected then if it's a non-secretory?
It is based upon the suspicion and the scan, because even though you have to, it will be detected that even despite the normal PSA patient has symptoms, you would just have to rely on the scan. So I tell you the reason is in the prostate cancer practice, when you see that many patients, you see somebody who's got a PSA value up to 3,000, you might actually be surprised to see a very little cancer on the bones. Somebody with prostate cancer goes from 6 to 8 will suddenly develop extra 5 or 6 spots in the bones.
Right.
You can most prostate cancers are secretory, which will have a rise in PSA. Then you can have a combination of secretory and a non-secretory PSA. And usually the non-secretory PSA is a lot more aggressive than the other ones. If you really suspect that there are symptoms, even despite 3 or 4 normal PSAs, the recommendation would be to do the MRI to exclude cancer. Right.
Thank you.
All right. Thank you, everybody, for your time today. And thank you so much, Dr. Dua. That was really very informative. Everybody, the recording will be sent to you within a day or so when it comes, and it will also be available on our YouTube channel. Again, thank you so much, Dr. Dua. Everyone, go and have a great rest of the day.
Thanks so much. Thanks.